Welcome to Unlocking EPSDT, Transforming Youth Mental Health Through Medicaid. I'm Heidi Baskfield, host of the Speak Our Minds podcast.
And I'm Jason Hopcus, host of Nobody's Perfect. We've teamed up for this 6-part series to share something powerful, something that could transform how we care for kids in this country, yet almost no one knows about it.
It's called EPSDT, Early and Periodic Screening, Diagnostic, and Treatment. A mouthful, but it's not just a policy term. It's a legal promise that's actually built into Medicaid, and it's designed to ensure that kids and teens get the right care at the right time before small concerns become big concerns.
And here's the truth. Nearly 40 million children in the U.S., more than half of all kids, rely on Medicaid. Yet most families, providers, and even lawmakers don't know what EPSDT is or their right to expect it.
So when families don't know what they're entitled to, they don't know what to ask for, let alone what to fight for. That means kids miss screenings, mental health needs go overlooked, care is delayed, or worse, denied, and the comprehensive system Medicaid was designed to be falls short.
We created this podcast to change that, to lift the curtain on what EPSDT really means and how it can become a game-changing guarantee for youth mental health if we understand it, demand it, and protect it.
Along the way, we're going to introduce you to bold leaders, everyday change makers, providers, policymakers, families, all who are showing what's possible when we treat EPSDT like the powerful tool that it is.
And we'll explore how you can be a part of that change, especially through something called the Learning Health Network. These are collaborative communities that bring people together, families, clinicians, advocates, and researchers to share data, challenge the status quo, and improve care in real time.
So this isn't just a podcast, it's a call to action. If you believe, like we do, that kids deserve better, and if you're ready to help shape the system they need, then this series is for you.
Fall in love with what Medicaid can be. Understand your power. Join us in building a movement where every child gets the care they deserve, early, fully, and fairly.
And it starts by unlocking EPSDT. Let's make sure everybody knows what it is and how to use it. Because the more we know, the more we can demand. And the more we demand, the more we build a system that truly works.
So join us, subscribe, and share this series. Welcome to Unlocking EPSDT, Transforming Youth Mental Health Through Medicaid.
And today, our incredible guest is Matthew Cook, who's president and CEO of the Children's Hospital Association, longtime leader and child health advocate. And we're so thrilled to have you with us today, Matt. Thanks for being here.
Oh, thanks for having me on. It's a great opportunity to talk about a very important issue.
Well, I think you're really unique given both your background and the role and the seat that you're in now. So it'd be great if we could start off just talking about, given that role, what are you seeing as the biggest challenges to operating a working system of youth mental health care in this country?
Okay. Well, first of all, how much time do we have?
Right.
This could take
Endless.
This could take all day.
Right.
But look, we didn't get here overnight. This is a challenge for this country that has been brewing for, let's just say, for decades. And we really have an imbalance between the services that are being demanded by kids and youth and our ability to meet that demand. And that's for a variety of reasons. I mean, we just simply do not have enough mental health care providers, regardless of, sort of what type of clinician we're talking about, whether it's psychiatrists, whether it's psychologists, whether it's, mental health workers. If you just take psychiatrists, for example, we have about 15 per 100,000 children, and that's about a third of what we need. We need more like 47. And so we had this longstanding issue with this tremendous imbalance between the amount of demand that we can service and the demand that's out there. And if you think about, well, what's the root cause of that? I think it's multifactorial, to be honest with you. These services are not reimbursed well. Clinicians in the behavioral and mental health space are not compensated well. So it's not an attractive field to go into. And for most organizations like a children's hospital, at best, these are break-even services. most hospitals lose money on providing these services. So it's really about how much money can I afford to lose in providing what is really an essential service to our children and teenagers. And so I think that's the conundrum that we are facing right now, is this, long history of underinvestment in the mental health infrastructure in this country.
Well, and the things that you're saying ring so true in the work that I've done in my own organization. And really, from your perspective, before we get in the nuts and the bolts of what we're really here to talk about, I'm just curious, do you see an increase in demand of the need post-pandemic versus what we experienced prior to the pandemic?
Well, that's a great question. And so I do think it varies a little bit around the country in terms of geographically. I would say on average, the answer is yes. So
Okay.
I actually worked, I've worked in a few different markets. I worked in California in the Bay Area. I worked in Indianapolis and Indiana. And I can tell you since 2020, the demand for mental health services in Indiana has gone up, significantly. And if you look at high school students, if you look at the Youth Behavioral Risk Survey and you look at the one from 2023, what you see is that nearly 1 in 4 high school students have come up with a plan to commit suicide, and almost 1 in 6 have acted on it. So those percentages are much higher than they were than if you look at the 2020 survey. So we do know that the demand for those services are increasing, and we know that our ability to meet the demand is not matching pace.
Well, and following up exactly on that piece, Matt, I mean, when we think about how significant those statistics are, when we think about the impact on young people and families and providers, like this is just like an overwhelming dynamic that continues to exacerbate the underinvestment that you talked about in creating sort of the strain and overwhelm. But where are you seeing some big strides? Like as these providers are sprinting to catch up and meet the need, and address this huge problem with suicide as a leading cause of death. Share what you're seeing as far as big strides in the space.
Yeah, Heidi, so you mentioned suicide. It is the leading cause of death for the age group 10 to 24. So that's actually quite shocking. It's quite shocking to me. And if you look at the number of individuals in that age group in particular that die due to suicide, it's 3 times the number that die from cancer. So that's a really startling statistic. So we have made such progress over the last several decades in treating cancer, and to the point where now more kids die by suicide than die by cancer. Why can't we make the same investment in mental health and preventing suicide that we've made in treating cancer? And so, one initiative that I think has been really important over the last couple of years, this is one that the Children's Hospital Association has been involved with, and it includes Cardinal Health and the Zero Suicide Institute. And we formed a national collaborative for preventing youth suicide. There are 40 children's hospitals that have been involved in this work. And it's really taught us, I think several good lessons in terms of what's really needed from the perspective of, emergency care, crisis stabilization. And so I think a lot of these children's hospitals have been able to take these lessons and apply them to their community. And that work has been really enlightening in terms of the number of children and teens that are screening positive for suicidal ideation or depression that really need care. And so I think that has been important in terms of highlighting what the real demand is versus what the predicted demand is. And I think what we'll see is this initiative, Preventing Youth Suicide, continue to bear fruit in terms of the number of people that are being screened, the number of people that are being referred for treatment, and the ongoing lessons learned that we can take in continuing to invest in the mental health infrastructure.
The statistics that you're sharing with us, they're just astounding. I mean, to even talk about these numbers, the fact that we're talking about it is really mind blowing to me. And that has proven out in the work that we've done in my own initiatives. As you know, you're part of a bigger series that we're hosting around Medicaid and its role in youth mental health. I guess to jump into that, given kind of the bigness and the severity of the crisis that we're facing, what role does Medicaid play in supporting youth mental health?
Well, that's a great question. So Medicaid actually is the single largest payer for youth and teenage mental health services. So it's because it's our largest and it's our most important. I think I would be remiss too if we didn't mention sort of the inadequate coverage that occurs on the commercial side. So we really do have problems regardless of whether we're talking about a public payer or a private payer. But let's go back to Medicaid, because that was really what you're asking me about. It is the single largest payer. And so back to my earlier comment about the reimbursement for these services. So as I said, most hospitals at best break even. It varies state by state because Medicaid is a federal-state partnership. And so some states reimburse at more adequate levels than others. But generally speaking, across the board, this is not well reimbursed. And so here's the problem that we find ourselves in, particularly given the discussion that's going on right now in Washington and the reconciliation bill and what the potential cuts are for Medicaid. When you make any cuts to Medicaid, you're forcing then the hospital, in our case, the Children's Hospital, to go back and decide what services can I still afford to provide and which ones do I have to scale back. And so when we're having this crisis, do we really want hospitals to have to go back and say, can I afford to provide the mental and behavioral health services that I am providing, or do I need to scale them back? That's absolutely the wrong conversation that we should be having. We should be having a conversation with Medicaid about how can you help us build the infrastructure in a much more robust way than we have today, and how can we reimburse these services? How can we make sure that children have access to mental and behavioral health services, not how do we restrict access? And so this conversation about Medicaid is really critically important right now, because any cuts are going to affect all children, not just children on Medicaid. It'll affect children on commercial insurance as well. And it'll affect kids regardless of their diagnosis, whether they have a behavioral and mental health diagnosis or not, something else. And so we're at a real crossroads with the Medicaid conversation, and we'll see how this plays out.
Well, and along those same lines, Matt, I mean, you are talking with all of the, major leaders in the delivery of pediatric mental health care and the impacts of prospective Medicaid cuts, $880 billion of Medicaid cuts. Can you just share some of what does doomsday planning look like for these leaders in this space? I mean, you're indicating, very real conversations about what services may have to be pulled back. Can you give sort of a little additional flavor on what is a ripple effect that comes from this level of decision making if huge components of these cuts actually advance?
Yeah, it's the right question, but it's also a complicated question because of how the Medicaid program works. So because it is a federal state partnership, Medicaid looks slightly different in each state that we have in this country. And so the proposed cuts sort of impact states potentially differently across the board. And so, some of the proposals that we were concerned about initially were per capita caps. We were concerned about reduction in the federal match. And those are not yet in the reconciliation bill. What we are seeing are potential restrictions on state-directed payments, provider tax, et cetera. And I think one of the challenges that we have with the Medicaid program is it is very complicated. And so not your average person doesn't understand the Medicaid program. And the reason why we have these things called state-directed payments, provider taxes, is that the base rate of reimbursement for Medicaid is so poor that these other programs were put in place as Band-Aids because the base reimbursement rate is so low. And so there's this belief that there's double dipping going on or something else going on for organizations that receive Medicaid reimbursement. That is absolutely not the case. We've just layered in additional funding levels because the base level is so inadequate. And so as we think about this issue of how states are impacted, interestingly enough, it's really more the red states that could be adversely impacted by cuts in Medicaid. And we'll have to see how that plays out and then what those states decide to do from at the governor's office and the state legislature to potentially make up or not make up for the cuts that are experienced in those states. And I think it remains to be seen if they're going to try and keep the Medicaid budget at the state level whole, or if they're going to introduce cuts, which will then lead to the conversation we just had. What are the programs I can afford to maintain, and which ones do I have to trim back?
Well, and in this climate of really having to balance all of that and recognizing that we've had increasing need and we're having decreased funding, I know there are some strides that are still being made to expand access to address the youth mental health crisis, specifically around the suicide awareness piece that we're having here. Can you give us a little more insight on some of the positive things that are still being done in spite of what we're facing?
Yeah, I mean, we have had the national, the 988 number and the text line. I mean, I think that has been very beneficial. I think what's interesting about that is if you look at the statistics of who's texting into that line, 75% of the texts are kids. So it comes back to this issue of meeting kids where they are and figuring out the best way to serve them. If you look at some of the programs that children's hospitals are working on, there's a few that come to mind. One is at Levine Children's, which is in Charlotte. It's part of Atrium Health. And they have a program called Meaningful Medicine. And it's really about bringing the care closer to, in this case, the teenager. I'm going to sort of use that. And so what this program is it allows kids who are in middle and high school the opportunity to receive counseling in their school so that they're not having to go somewhere else to receive it. And the benefit of that is, when they have an appointment, they can go into an empty office, they can go into an empty classroom and pull out their tablet and log into their counseling session. Their families can join them, the parents can join them if that's appropriate and noted by the clinician. But what that program has done is it's reduced the wait time that kids have in getting their first appointment. And I think that's really critical. It's that time to that first appointment, that time to understand what's really going on so that the appropriate resources can be wrapped around that patient. Children's Wisconsin and Milwaukee has also done some great work. I think they figured out that it wasn't just enough in their market, because in Wisconsin, you have an inpatient hospitalization rate for mental health that is, I think, 4 times the national average. So they have really heavy inpatient utilization or admissions for mental health. And so for them, investing in the school program, which they've done, that itself wasn't sufficient. So they created this mental health access center that you can call and more quickly, sort of matches services to the situation in an appropriate way. And so those are the types of programs we're seeing around the country that I think have been incredibly beneficial, and there are others. But if I think to what would I say to Congress? One, I'd go back to the Medicaid conversation that we just had, which is don't cut Medicaid. But two, there are some bipartisan efforts that have been out there. There's a bill called the Early Minds Act, which would grant states some flexibility in using their community mental health block grants, some portion of it, to really focus on prevention and, sort of early intervention. And, I think that's a real low risk, intervention or bill, if you have it, that is bipartisan, that could, potentially reap some benefits in at least understanding what's the best model in certain states to reduce the burden.
I'm going to ask this question. We're all really concerned about the future of Medicaid, and there's a very significant recognition of the critical role that Medicaid plays in all of this, Matt. But it feels like in this moment, we can either sort of watch the gains that we've been making over the last few years, sort of building off of the momentum that has been generated from things like the National Declaration of the Youth Mental Health Crisis, or and fall backward from that, or this could be one of those pivotal moments where we use it to think very differently in how we approach this. I'm just curious, sort of, what your thoughts are on that. How can we not be broken down and continue to innovate? I mean, the examples that you're giving are good examples of those things, but what are other obstacles that we can take innovative approaches around to keep addressing this crisis and not lose our footing?
Yeah. Interestingly enough, this is an issue that also varies sort of market by market. So I remember when I was in the Bay Area, one of the challenges that we had in the Bay Area is if you had a child that required inpatient care for a mental health diagnosis, there were no inpatient beds. So
Right.
that child either had to go to Southern California or leave the state. Now, in other parts of the country, we actually have enough inpatient supply, but what we're lacking is intensive outpatient services or day hospitalization services or crisis stabilization. So this is where we need to work, I think, at a community level and really figure out, here are all the pieces of the puzzle, school programs, crisis stabilization, et cetera. How do we knit them together so it serves the needs of this community? And I think that's the part that we have not done well in this country, is we have these bits and pieces that we've all invested in, but they're not tied together seamlessly. And I think there's work that Congress could do to encourage that. When I talk about this Early Minds Act, that's not all this. That's one piece of this puzzle. But there's certainly legislation and support that the federal government could do to help this along. Because at the end of the day, what do we really want from a functioning mental health infrastructure? We want early intervention. We want early treatment. We want little to no wait times. We want, services that a family, a child in particular, can access that's holistic. And so if we keep those aspects in mind and think about how do we achieve that in the community, then I think we'll come up with something. But I think this is where the federal government has to encourage it. And quite frankly, so do the states.
Well, and what I'm hearing is really a full development of a robust roadmap around how do you access care and get support. And I've always looked at it, the shortest line between I am struggling to I got connected to resources that could help me. And what I love about the initiatives that Children's has taken on is in some of these external safety net programs is creating that value outside of what I'm going to call the system, which I think is really important. But as somebody who provides those supports outside of the system that doesn't provide direct care, I'm going to use my organization NAMI as an example. We're really still up against that same wall that you're facing, is how do you pay for it? Because I think these system resources shrink, people become more reliant on community-focused resources, and they're maxed also and don't have the funding that's necessary to make these things sustainable. So I hear what you're saying about government getting involved and really helping sustain the safety nets across the board. But, given the environment that we're in, where we see everything, wanting to contract and really maybe implode, so to speak, how do we start to do that more thoughtfully, knowing that we may not have the reliance on the government that we've come to rely on? in the way that we have?
Yeah. So, one way that we do that is we do that through philanthropy, and we look for, private donors who have an interest in bettering the situation for children and youth. That's one part of what we do. There are certainly foundations, and then there's certainly the state government, and there's the local governments. And so I don't think this is, we are so far behind that not one single player is going to solve this problem. And what we really need is everybody to come together and actually fundamentally agree that children and children's health is a national priority, because we've not actually agreed on that. This country has not agreed that children's health is a national priority. And if you think about health holistically, it's not just physical health, it's mental health. And if we can agree that it's a priority nationally, then, I think that can spur different dialogue. But we've not even had that conversation yet.
And when we think about how the data shows that so much of adult mental health issues start in childhood and why it's so important to invest in that space, I mean, to your point, Matt, like if we want to create a working system that actually saves money over the long term, you start with kids. So what does success look like in that space?
I mean, absolutely. I mean, the point you just made is really critical. Most adult mental health challenges appeared when they were children. They didn't appear when they were adults. They appeared when they were children, and we didn't catch it, or we didn't intervene, we didn't diagnose, we didn't treat. Something didn't happen, and so that's why it's so critically important that we prioritize kids and go back to the standpoint of, if you want a healthy generation, a healthy future, it actually starts with the children. Because if you neglect the physical and mental health needs of children, you create an environment for the adult generation that is much more heavily dependent on care, and it's more expensive, and we're less healthy. So this is really about sort of turning the rubric around and saying, if we want a healthy generation, then let's start with the kids. And then that means we have to go upstream and really think about what's going on in the schools, what's going on with social media. How do we start to mitigate some of the risk factors that we've created for kids? And how do we figure out how to identify really quickly when they're happening? And that's not in the hospital. I represent the Children's Hospital Association, but that's not the hospital. I can tell you, when a child shows up in one of our emergency departments, we're already behind the 8 ball. There's way too much that's already happened that should never have happened. And so this is really that's why I say it's a community issue. This has to be resolved at the community level, probably, using schools in a very central way. And so we need to flip this mindset that, for example, this is not a children's hospital issue. We are part of a solution when somebody's in crisis, but this really needs to be resolved in the community.
Yeah, I really hear that. And having done work for the better part of a decade in serving the families that are affected and impacted by mental health, I recognize that it's, it does take a village to do this work. And I wholeheartedly agree with you that when somebody shows up at your hospital, there are many things that have happened that, to your word, should not have already happened. I guess what's fascinating to me is you kind of sit on the leading edge of understanding this. Like, from your perspective, what role do you see technology and innovation now that things are moving very quickly, with the integration of new technologies? How do you see that serving a role, if it does, in advancing, how we solve some of these challenges with youth mental health?
Yeah, I absolutely think there's a role for it. I mean, when I was giving the example about Levine Children's in Charlotte, I mean, they're using tablets to, connect with their clinician, which, 10 years ago, I'm not sure that would have happened. So I think in terms of screening, in terms of diagnosis, I think we can use technology to really assist us in helping understand what's going on. I do think the piece that we don't have yet is a lot of evidence-based research on how technology impacts diagnosis and treatment, and how supportive it is, and how effective and efficacious it is. And so that's the one caveat I have is, as we should absolutely be applying technology to help us, because we need technology as an adjunct to the fact that we don't have enough manpower. But we also understand where it has its best uses and what its limitations are. And so that's just a piece that we're going to have to explore over the next several years, is how do we effectively bring it in?
If you want to just take a minute too, as you're thinking about technology and telehealth and impacts created by workforce shortages. I mean, where these tend to play themselves out, right, are in our rural communities. Can you say more about that and where these solutions could really come in handy there?
Yeah, so absolutely. So one of the challenges we have when we talk about our shortages, these shortages impact different areas of the country very differently. So some areas have a much more fundamental shortage of clinicians to help. And in particular, that often occurs in rural areas. And so this is where technology can be incredibly helpful in terms of telehealth, in terms of apps that help support access or help support children who are going through a mental health crisis. And so this is where we need to be really smart about looking at all the different options that are open to us, looking at the communities that are underserved from a geographic standpoint. What manpower do they have? What don't they have? And how can we use technology to fill the gaps rather than make them potentially travel to somewhere where they really can't afford to go or can't logistically, make that happen? And so this is the benefit of where we are from a technology standpoint, particularly with something like telehealth. This can be incredibly important as we think about the children and the teenagers that are in much more rural parts of the country.
Well, Matt, I mean, you've been so insightful in giving us really kind of the nuts and bolts with this, and I would love for us to end on a high note. Being that we're standing on the precipice of really a lot of unknown, paint the picture for us. Like, what could youth mental health look like if we get this right?
Yeah, well, look, I think the first thing that's really positive is we actually have so much more attention now on the fact that we need to invest in this infrastructure nationally than we ever did. So I think that's positive, right? If we weren't talking about this, if we weren't calling attention to this, if we weren't shining a light on it, then that would be worse. And I think nationally, we've done a really good job of framing this issue through the emergency declaration, through the work we've done with the federal government and the state government. So I think there's really good awareness, and that's really step one. And I feel confident, I feel positive that there's a recognition that we have a problem, and that we need to figure out how to make that, sort of mitigate that. But I think it comes back to, what does success look like? I think it comes back to something I said earlier. I mean, we need to have early intervention, early assessment, early diagnosis, so that we can prevent issues from happening in children that continue through adulthood. And we need to ensure that we are not creating long wait times for individuals who have been assessed for needing services. So, months-long wait times are not helpful. We need to have zero wait times, 1-day wait times, which in part comes to then what are some of the solutions? When we talk about the school programs, we talk about crisis stabilization, those are all pieces of a puzzle we don't really do well today, but they're all geared towards, sort of immediate access. And then this picture that it's holistic, that we're removing the stigma about mental health, that it's one aspect of health in general, and that it's not only just okay, but it's our obligation to treat the whole child. And I think that's what success looks like, is treating the whole child in a timely way and in a way that is easy to access.
Matt, those insights are fantastic. I think it's a perfect way to wrap up our conversation. Thank you so much for making time to join Jason and I. And we look forward to future conversations and hopefully coming back in a few months and talking about the Medicaid advocacy success story. So thanks for being here, for all the work that you're doing. And we sure appreciate the time.
Thanks for having me. Appreciate it.
It was a pleasure.